So my name is Jeff Rolfe. I'm a neuromuscular neurologist, and I'm happy to have two folks with me from UCSF. Ann Urado, our neuromuscular nurse, and then Dr. Paula Santanero, a clinical fellow who's going to join our faculty next year. So our plan for this morning are to have 3 talks. I'm going to give a few introductory remarks about peripheral neuropathy, and then Paul is going to go through some cases and sort of highlight the experience of a patient being worked up for neuropathy, and then I'll speak after that and relay some new stuff that was presented at the American Academy of Neurology meeting, which is actually currently still going on. It goes on for the whole week. So I think up on this slide is the structure of our talk, and we'll get started. So as you know, neuropathy means a disease of nerve. And first of all, neuropathy is a very common problem, as you know. I know there's a statement on the WNA website how it's the most common disease you've never heard of, and that's really true. And the overall prevalence is a little hard for me to read from the back, but I think it should say about 2.4% of the population. And if you work that out in the United States, that works out to about like 20 million people, 15 to 20 million people. So it's a very large number. And it's much bigger than the burden of Alzheimer's disease, which is more like 2.5 to 5 million, or Parkinson's disease, which is around 1 million. And everybody's heard of those diseases, but not so much neuropathy. And again, I know the print is a little bit small, but basically it's a common disease you haven't heard of. And I guess the important thing is that this is a painful condition for many of you. And I know for some of you, the problem is balance and weakness, but probably most of the people in the audience, pain is the main reason why you're coming here today. Who here in the audience has neuropathic pain? So quite a few hands. I'm surprised there are actually not more hands. It's often a major motivating factor for people to join support groups. So just to make sure we're all on the same page, some of these slides are very basic, but we're talking about peripheral neuropathy, and what the peripheral means is the peripheral nervous system, which is in the box there. It's not the brain and spinal cord, that's the central nervous system. We're talking about the nerves in the trunk of the body, and the nerves in the limbs, and also the nerves that go to the organs, the autonomic nervous system. In a way, the English language is inadequate to describe the nerve. I mean, it's almost like, remember the Smurfs? They use the term Smurf as a verb and a noun. Well, we use the same word nerve to mean the nerve trunk or an individual nerve fiber. So this slide just shows how you have individual microscopic nerve fibers that we also call nerves, and the fatter ones are surrounded by a fatty sheath called myelin, which increases the conduction property of the nerve. Okay, and motor nerves go to muscle and are responsible for movement, and nerves, of course, in the skin carry information the other way towards the body. And I think the animation got screwed up there a little bit, but there's supposed to be a little green leaf that touches the skin. There's a little electric impulse that goes towards the spinal cord. So your motor information goes outward, the sensory information goes inward to the body. The nerves that go to the muscle are all large fibers, meaning that they have a large diameter, whereas the sensory fibers are more highly variable in terms of their diameters. So a large fiber is a fiber with a large diameter, and those sensory fibers mediate things like vibration sensation and discriminatory light touch. And then the small fibers are the pain and temperature fibers. And this relates to at least one of the cases that we'll discuss about later on. Many of you have a process in which the distal part of the nerve is diseased. So it's so-called dying back axonopathy, and that's what I've depicted in this slide, is sort of those little dotty parts of the nerve. So if the nerve dies back, then when you want to move, the impulse can't get to the muscle, and then if something touches you, the information can't get to the nerve. Now, a mystery to many patients is the paradox of peripheral neuropathy, how you can be numb, have numbness and pain and numbness in the same location. The numbness makes sense because there's just not enough nerve fibers, so the pain is a more difficult thing to explain. And the main reason that there's pain is that the nerve fibers that are still there have changes in the expression of molecules on their surface that lead them to fire more readily, and sometimes without any input whatsoever. And that is the basis of most neuropathic pain. And many of you experience the wide range of neuropathic pain types. It can be anything from itching is the main symptom, to burning, stabbing, a swollen feeling. A very common sensation is that there's like something on the sole of the foot, like a pad. There's something changed about the tissue seems swollen or too thin. Let me just put all these things together. So a neurologist, when we think about neuropathy, one of the first breakdowns in how we think about it is whether it is a focal or a multifocal neuropathy, or sort of just a single nerve, or is it a patchy process, or is it symmetric and generalized? So a common example of a focal neuropathy would be carpal tunnel syndrome, which, by the way, can coexist with a sort of a standard neuropathy, for example, in somebody with diabetes or amyloidosis. Many of the people here, I imagine, have generalized neuropathies, and then we further subdivide those into axonal or demyelinating types. The reason this is important is because there are specific treatments, particularly for the demyelinating neuropathies. There are specific treatments for those. So we kind of need to pair up the patient with the treatment. So it's important to figure that out. The symptoms of polyneuropathy, well, many of you live with this every day. It starts off usually with numbness or tingling or pain in the feet, and then over time the symptoms work their way up. This is over months to years, from the foot to the mid-shin area, then to the knee. And then when the symptoms get to the knees, that's usually or often when the hands can get affected. And this sort of cartoon sort of illustrates that with the involvement first in the feet and then in the shin area. And then again, when it gets to the knees, then the hands are often affected. Sometimes the hands can be affected early on. And if the hands are affected early on, that does sort of shift the neurologist's thinking about what could be going on. The causes of polyneuropathy, Paul, when setting up his talk, he says, wait, you're forgetting some things. And I told him that I kept it to 5 categories because that's the number of fingers I have in my hand. And when I discuss with patients, I like to just touch my fingers. So the one finger is, in terms of cause, is the neuropathy can be connected to some medical problem. So there's a medical illness that's driving the neuropathy. And in a way, I think we were always trying to find that, because the best way to fix a neuropathy is to find an identifiable cause, and then we could, if we address that cause, then we could fix the problem. But there are a variety of medical disorders associated with neuropathy. Again, I know the print is very small there, but advanced kidney disease, liver disease, I mentioned this thing called amyloidosis, where you have a deposition of protein in tissues. There's a long laundry list of medical problems. Another category are toxins and medications, and the patients that we see, this is mainly connected or caused by pharmaceutical drugs the patient takes, and many pharmaceutical drugs is, one of their negative effects is neuropathy, and sometimes it's very predictable, but the drug is so necessary that we sort of live with the neuropathy, or the neuropathy risk. So there are a number of toxins. Alcohol is another major toxin to the nerve. And then the other category is vitamin deficiencies. Usually this is mainly B12 deficiency, but I have a case that I'll present later on that illustrates how other vitamin deficiencies can play into it. And then I think I'm on figure number 4 now, hereditary. So there can, there's genetic factors are at play, very common, quite commonly in neuropathy. Maybe about 20% or 30% of our cases have a genetic component. And then the last category is the feared idiopathic or cryptogenic. And in our practice at UCSF, this is a very high percentage because many of our patients come from other neurologists and they've already been worked up. So we sort of have in our clinic the ones that are trickier to figure out, and I would say about 40 to 50% of our patients who come in with burning or tingling in their feet, about that percentage have a neuropathy of unclear cause. And anyway, that's idiopathic, is the number 5. So I think that is it for my introduction, or the introduction part of this talk, and now I'm going to hand it over to Dr. Samponero for the next part.
Dr. Ralph and I thought it would be helpful maybe to take some of this broader information and apply it to a few cases, both to illustrate some of the ways that we as neurologists approach neuropathy. Thank you. And also just to apply some of this so that it maybe is a little bit more relevant to you as patients and individuals. I think the other thing that's nice when we talk about cases is we can talk about some primary therapies, some of which you may or may not take. But the categories are growing and we have more and more treatments than ever before. So the last thing I would like to do is provide a little bit of optimism about sort of the rapidly expanding treatments that we now have at our disposal, and that's changed a lot even in the last 5 years. So case number 1. So this is a 72-year-old mechanical engineer. He has a past medical history, which we see often, similar things, hypertension, type 2 diabetes, history of coronary artery disease. He had a surgery for a bypass graft in 2010. And he came to see us 4 or 5 years ago now with burning, tingling, and numbness in his toes. He had no weakness and no balance problem, but his primary symptoms was this pain. And I know many of you have probably relate to this gentleman. So as a neurologist, we tend to follow a stereotyped kind of evaluation, and then as we go through talking with the patient, we start to fine-tune and individualize the care based on what we hear. So we always take a history and we ask, for example, is there a family history of similar symptoms? We look for things like toxic exposures, which include alcohol use, for example. We think about patients' past medical histories, what other things they may have been exposed to in life. And then invariably we do a good neurologic exam, which includes both an examination of the feet in the area that's in pain or the area that's weak, and then a detailed neurologic exam. And we often, after we see a patient, we'll send them to the lab to get blood work done, looking for common causes of neuropathy. So we'll check things like diabetes. If in their exposure history we hear about potential risks for things like hepatitis C, we'll check for that. And then just to get a little bit more clarity on the neuropathy and what's involved, oftentimes we'll refer patients for an electrical study, which I'm sure many of you have had. This is called an EMG and a nerve conduction study. Rarely, if the case is particularly confusing, we also sometimes will refer a patient for a skin or a nerve biopsy. But I would say that's probably done in a small minority of cases. So this is just going back to Dr. Ralph's slide, talking about the differential that we think about, and we sort of go through this in our mind based on what patients tell us. And in this particular case, this patient had an EMG and nerve conduction study that showed a mild length-dependent polyneuropathy that was mostly in the feet, really not involving his hands. And then when we were reviewing his lab results, we saw that this patient's hemoglobin A1C, which is the test that we follow for his diabetes control, had gone up in the last 3 years. So it went from a 7.3 to a 9. So this was in the absence of anything else, this is a really good story for a diabetic polyneuropathy. And as Dr. Ralph mentioned, it's the most common polyneuropathy that we see. So that I would say if there's a good history of this and if the history of diabetes, worsening control, and the right symptoms, this is most of the time what it's going to end up being. It's diabetic polyneuropathy. The mechanism of diabetic polyneuropathy in part has to do with the actual sugar, increased sugar in the blood, causing these glycosylation products which end up accumulating in different parts of the body. And then the sugar itself is not good for the small vessels that supply oxygen to the nerves. And so microvascular injuries can happen and damage the nerves directly. So when we think about polyneuropathies in general, I would like to argue there's two kinds of treatments that we think about. We think about first the primary therapy, what can we do to actually stop the disease process itself? And that varies depending on what kind of polyneuropathy you have. So in the case of diabetes, we think about treating the diabetes itself, so treating the systemic illness. In the case of a nutritional deficiency, for example, we would treat and replete somebody of their vitamin B12. And then the secondary kind of treatment we think about are how do we manage a patient's symptoms. Oftentimes it's the pain that's unbearable. Patients don't notice that their hemoglobin A1C and their diabetes control may have worsened over the last few years, but they certainly remember and appreciate the pain. And so that's equally as important a job that we do. And so in this case, for the diabetes, we're going to focus on treating the underlying condition, which is the diabetes, and we're going to focus on treating this patient's pain. So there's evidence to suggest that actually tighter glycemic control in diabetes can actually help the polyneuropathy. And I'm sorry that you probably can't read this, but these are just pointing out a few studies that were done in the past that suggested that when patients' glucose control is better, their neuropathy sometimes improves or at least plateaus and doesn't get any worse, or if it does get worse, it gets worse much more slowly. And so that's the first part that we do. And then I think in the case of diabetes, oftentimes a lot of the focus in our discussion, in addition to glucose control, is often how do we treat this pain. And so I would like to take this case and focus a little bit on our approach to neuropathic pain and how we manage it. I think sometimes that can be a little bit mysterious to patients why we pick one drug over the other. So my hope is after this, you'll have more of an understanding of what our thought process is and how we approach neuropathic pain. So I would say the first thing that we do, I'll go back to this slide, is the American Academy of Neurology has a list of medications that they recommend, and anecdotally we have medications that we see patients respond to. And so we often will pick a medication based on a patient as an individual, what sort of past medical history they have, what sort of side effects we're maybe trying to avoid. And so we'll usually pick one drug, and we'll start it at a low dose, and we'll work our way up as needed. And so you'll see here, scenario number one is, let's say, for example, we start a patient on Gabapentin, which I'll talk about more in a minute, and they have a partial pain relief at the low dose that we started. Well, in that case, we'll just increase the dose and keep them on one medicine for their pain until we get adequate pain relief. And the goal here is to get adequate pain relief while also minimizing any potential side effects that a particular drug might have on someone. Well, scenario number two often happens as well, where we'll have somebody on gabapentin and we'll max out the dose. And so in that case, if the pain is not completely controlled, then we'll often consider adding a second therapy. And the strategy in adding a second therapy is to pick another drug that has a different mechanism of action, the idea that you're targeting two different areas of the nerve to try and improve the pain, while also minimizing the number of drug-drug interactions. And then scenario number three, which certainly does happen, is we'll start a patient on a medicine like gabapentin, and they have no response whatsoever. It just does not help their pain at all. Well, there's no reason for us to keep a patient on that medicine, and so we'll take them off that medicine and try an alternative therapy to see if that might work. There's obviously many pitfalls to treating neuropathic pain, and there's some challenges involved. Finding the right dose and the right medication is an individualized effort between a neurologist and the patient. Oftentimes patients will experience side effects, and so we have to balance that. Some of the neuropathic pain medicines, like gabapentin, for example, you have to take quite frequently. A lot of patients find it very inconvenient to have to worry about taking a medicine 3 times a day, for example. So we think about that too. And then, as Dr. Ralph was mentioning, the prevalence of neuropathy increases as we age. And so often our patient population tends to be middle-aged or our senior population, and those folks tend to get more side effects with drugs, and they tend to be on more than just the neuropathic pain medicines that we're prescribing, and so the risk of so-called polypharmacy increases in this population in particular. So we're always trying to be mindful of that. So let's take the first medication that I'm sure many of you have experience with. It's sort of our tried and true drug. It's gabapentin. Gabapentin has an interesting mechanism of action. It binds to voltage-dependent calcium channels. And the goal of it is really to sort of turn the volume down on the pain response. It's a good medication. We often prescribe it. It's first line. It's generic, and so it doesn't cost much for patients to start it. Many of our patients do quite well on gabapentin. I think the biggest downfalls of gabapentin are the frequency of the dosing, 3 times a day, and there's also a fair number of side effects from gabapentin, including some patients experience cognitive dizziness or clouding. Some folks experience weight gain. And most of the time, the reason we stop gabapentin or switch gabapentin is because at a high enough dose, patients are feeling these side effects and they don't like that, and they'll take the pain rather than the cognitive fuzziness that they feel. I guess it's not a new kid on the block anymore, but Pregabalin or Lyrica came out certainly more recently than gabapentin, and it's actually going generic in the summertime. And it's a similar drug with a similar mechanism of action, but it's more potent than gabapentin. And I've anecdotally had patients who feel that it doesn't have quite the same cognitive side effects that gabapentin does. So oftentimes, I know I personally, if a patient isn't doing well on gabapentin, I'll try to switch them over to Lyrica and see if that improves things. And hopefully that becomes easier to do as this medication goes generic in July. Another class of medications that may be considered are the quote-unquote anticonvulsants. These drugs, I'm sorry that the slides are small, or the words are small. These drugs actually started out as anti-seizure medications, but the properties that help prevent the overexcitation in the brain that happens with seizures are the same properties that can help the overexcitation of nerves that happen in neuropathic pain. So occasionally, although it's not often the first drug that we will choose, we will pick one of these anticonvulsant drugs as a second-line therapy. And these include things like carbamazepine, oxcarbazepine. Rarely, but occasionally we'll put people on medications like Topamax, for example. Sometimes this works out because if a patient has a migraine headaches in addition to neuropathy, sometimes Topamax can treat both with just one drug. Another category of medicines that I personally like are they fall under the category of antidepressants, but we find that they're very, very helpful for patients with neuropathic pain. So the tricyclic medications, which include things like nortriptyline, also known as Pamelor, or amitriptyline, also known as Elavil, are medications that work on norepinephrine and to some degree a little bit of serotonin, and can modulate the pain response through multiple mechanisms. The big side effect with the tricyclics, however, is that some patients feel that it makes them a little bit sleepy. Other patients feel that it gives them a dry mouth and they don't like that. Some people experience weight gain on the tricyclics, and so you can see there's a recurring theme. A lot of times what we try to do is balance the side effects with the effect of the drug. Also under the category of the antidepressants are the serotonin norepinephrine reuptake inhibitors, and these include things like duloxetine or Cymbalta, which I'm sure many of you have tried, also Effexor. And these medications, duloxetine in particular, are first line and FDA approved for the treatment of diabetic neuropathy. You may have noticed that we don't prescribe things like Prozac for neuropathy, and that's because the drugs that specifically just act on serotonin don't seem to really help people with neuropathy or neuropathic pain. It may help them if they're depressed about their neuropathy, but it won't help them for the pain specifically. Tramadol is an interesting one. I'm not sure, I don't know if you, Dr. Ruff, prescribe this more than I do. I don't tend to prescribe this that often. It's a medicine that is similar in that it blocks norepinephrine and serotonin reuptake, but it also has a weak binding on the mu opioid receptors. So it's sort of, in some ways, like oxycodone light. It can partially modulate these responses, and there's been several studies to show that this medication is effective in neuropathy. I think opioids, for a lot of patients, particularly patients who are in severe pain, is one of the elephants in the room when you come to see a neurologist. And I think part of that is because opiates are effective. The issue is that they have a high addictive property, and there's been a lot of press, as you know, of patients abusing opiates and lots of deaths related to opiate overdoses. The medications themselves are really best used for short-term purposes. So for example, an orthopedist, if a patient has a broken arm, may prescribe a short course of oxycodone, but they're not great medicines because of their addictive properties chronically. And oftentimes when we're dealing with neuropathic pain, these tend to be more chronic pains that we're dealing with. So you may notice that neurologists in general, with some exception, will try to avoid these medications in patients. And that's only because we have many other therapies that don't quite have the addictive properties, and quite frankly don't have the stigma around opioids. I think an underappreciated category of neuropathic pain medications are the topical ones. So lidocaine patches for some patients can be very effective, and their big benefit is that they don't have a lot of systemic uptake. So you can put lidocaine over the feet and get that pain relief that you're looking for without feeling doped up on an opiate, for example. Capsaicin too is a popular one, and it has an interesting mechanism. So capsaicin is from the chili pepper, and the idea is you actually put something that causes the feet to burn even more, so that you kind of deaden the nerves. The brain just says, something's going on here, I don't understand it, and we're just going to sort of turn off the pain response. Capsaicin for many people can be effective. The only big side effect I hear about is people will rub the capsaicin on their feet and then accidentally scratch their nose or rub their eye, and then you have another problem going on. But capsaicin can be quite effective.
It just acts.
Lidocaine in the form of Icy Hot is also effective, and there's also hemorrhoid creams that some patients have used because they're cheaper, like Recticare, that can also be effective on the feet, believe it or not. Nutritional supplements are an interesting topic, and I have a suspicion that some of you may be taking things like alpha lipoic acid or L-carnitine, and oftentimes in clinic, I probably spend 5 to 10 minutes discussing things like, are these supplements helpful? And I think the short answer is that there's a bit of a mixed bag. There's been some evidence that maybe things like alpha lipoic are helpful in that patients feel like they have less pain when they take it. But the data on nutritional supplements has been a little bit mixed. You know, we have a Q&A session coming up. If you have a specific question, I think Dr. Ralph probably would be able to answer some of these a bit better than me. But this is something that patients do take, and I personally don't mind that they take it if they feel like it's helping. This slide may be a little bit dated, but as you know, in the state of California, not only can you get medical cannabis, you can get regular cannabis, and some patients feel that CBD oil or marijuana, even in this form that has THC in it, can be helpful in improving neuropathic pain. Be happy to answer other questions like that in the Q&A session as well. Another common thing that patients will ask us about are TENS devices or electrical stimulation. And it comes in many forms, and the general idea is It's actually similar to the capsaicin, I think, where you provide an electrical stimulus to the nerves. And there's something about adding that stimulus can help with the neuropathic pain. I don't know if there's a ton of evidence behind its efficacy, but for patients who do feel like it helps them, I don't see really any side effects from it. So I often tell my patients that they can keep using it if they'd like. And then there's some other things which also I think the jury's out on, but patients anecdotally have argued that it's helpful. Things like acupuncture. Some people put magnetic insoles in their feet, something about the magnetic field being able to help the neuropathy. And so there's a lot of other things out there that people have tried in addition to the pharmacologic therapies that they anecdotally feel are beneficial. Case 2. So if that was about sort of neuropathy from a systemic condition and a discussion of neuropathic pain, case 2 is about a 50-year-old attorney who has a slightly more rare condition. So she came to the clinic reporting 5 months of difficulty climbing stairs and then 3 months of frank gait imbalance just when standing up, and she had numbness and tingling in her toes. And then a month prior to seeing us, she felt that she had difficulty buttoning her clothes and her fine motor in her fingers was impaired. So again, as a neurologist, we have a sort of stereotype rubric that we follow, and then we again fine-tune things based on the history. So again, we re-elicited this history from this nice lady, and then we did our neurologic exam. And interestingly, on neurologic exam, unlike the first patient who had mostly sensory problems, there was a lot more weakness that we appreciated distally in her legs. And we also noticed that her reflexes, which, as you probably noticed, neurology, we love reflexes. Her reflexes were noticeably absent everywhere, even in her arms above her hands, where her strength was otherwise quite good. And then she also had impaired sensory function in her toes, and she couldn't feel the vibration of the tuning fork in her toes, in her ankles, or even her knees. We again recommended a battery of lab tests, which we sent her for, and then we again, to further characterize her neuropathy, sent her for an EMG. Interestingly, her EMG, like the first case, showed a neuropathy, which was a bit worse and had progressed more than the first case, but it also showed this pattern of slowing of the nerve conductions and areas of conduction block where it seemed like the nerve signal just couldn't get through. And that pattern where the nerves firing, but are firing much more slowly, and there's areas of block, that is a pattern that is concerning for demyelination. So Dr. Ralph mentioned that you have the nerve, and the nerve is like a wire, and you have the copper in the wire that sends the signal, and then you have the rubber around the wire, which provides the insulation for the conduction to travel down. And myelin is a protein that provides insulation for the nerve, and it looked like she had a problem with the insulation of her nerves, which is why the signal was getting sent more slowly. So based on that, we were suspicious for a relatively uncommon condition, and so we actually did a spinal tap or a lumbar puncture, and we noted that although she didn't have any infection in her spinal fluid, she had a high protein level in her spinal fluid. And that pattern of slowed nerves and an elevated spinal fluid is a classic example of a condition known as chronic inflammatory demyelinating polyneuropathy, or CIDP, which is a much easier thing to say. This condition, unlike the other condition, is an autoimmune attack on the nerves. And some of you may have heard about Guillain-Barré syndrome. This is sort of the more slow, bumbling cousin of Guillain-Barré syndrome. And it has a similar pattern that just happens much more slowly over months rather than days to weeks. The reason I wanted to show you this example of CIDP is this is another example of how we think about why understanding what's causing the nerve injury can be helpful. So in this case, because she has an immune-mediated attack on the nerves, rather than treat her blood sugar, we're focusing on treating her immune system and quieting down her immune system. And then because she wasn't having a whole lot of pain, she was having mostly weakness, our focus was not on neuropathic pain medicine, but rather providing her with assistive devices to aid in her mobility. So in CIDP, which is an immune attack on the nerves, we have several immunotherapies, and this is a slide I took from Dr. Ralph. I agree, we sort of think of it in a triad where all three of these medicines, which I'll go into, can be effective. So some of you, for other conditions, or if you have CIDP, may have received intravenous immunoglobulin, also known as IVIG. The way IVIG works is actually a little bit unclear. We think that flooding the body with this immunoglobulin does something to modulate the immune response and quiet it down. The pros are that it's very, very effective. The cons are that it's an infusion, and there can be infusion-related reactions, and it can often lead to people feeling almost flu-like with fever, rarely, but chills and muscle aches. Sometimes people can also have an allergy to IVIG. But when it works, it's very, very effective. Another thing that we use, which some of you may have also been on in the past, are steroids. So in these conditions, we can also use things such as prednisone to treat the nerves, and the effect can be rather quick, over a few months. And the pros are that it's much easier to take a pill than it is to go to an infusion center and receive an infusion. But the cons are that there's all sorts of side effects of steroids, some of which you may know about, including things like worsening your diabetes, worsening your blood pressure. People who take steroids chronically can have changes in the way fat is deposited in their body. So this woman you see right there who's been on steroids chronically has a lot of increased fat in her face, and that can be a chronic sign of it. But the medications are effective, and often patients will take this if it means that they can walk. And then the last therapy is something called plasma exchange. This is a pretty involved therapy, but it's very, very effective. It involves a patient often coming into the hospital, getting a catheter placed, and exchanging her plasma or his plasma for a filtered plasma that doesn't have the immune proteins that are causing the attack on the nerves. And the benefits are that it's very, very effective. The downsides are that it's much more invasive than the others. And then obviously this patient, this lawyer who came in, was having difficulty walking. And so in addition to thinking about how to treat the nerves themselves, we also wanted to focus on improving this woman's function. And we have lots of things that we have lots of things at our disposal. So we often will have a physical therapist or an occupational therapist see these patients alongside us, and they can help us fit patients with canes, orthotics and braces to help the weakness that they have in their ankles and in their feet, for example. These are a couple of braces known as AFOs, or ankle foot orthoses. And then we'll often prescribe some sort of course of physiotherapy, things like Tai Chi or PT sessions with specific focus to gait and balance training can be very, very helpful, and they are a critical part of our treatment of patients like this. And lastly, case 3. So if the first case was diabetes, which is very common, and the second case was CIDP, which is less common, the third case is also in the less common category, but I think it's illustrative of where we're going with medicine and with neurology in general. So this is a case that Dr. Ralph and I recently saw of a 55-year-old man who was a construction worker who had a history of glaucoma, and he had a pacemaker placed a few years prior. And he came in with a much more chronic history. So rather than days or months, he had 3 years of worsening gait that was associated with pain, numbness, and weakness in his feet. He had sort of thought that maybe on the job, after he'd been on his feet all day, that he had just this pain and numbness, and it was work-related, but eventually he sort of realized that it was much far out of proportion to what he should be expecting after a long day's work. So again, we took a history, and interestingly, in this history, he had a couple of things which were quite notable. So he did have a fair bit of alcohol consumption, but more interestingly, he had a father with similar symptoms. And his father, he told us that his father had a neuropathy in the past, and they didn't know what had caused it, and he was ultimately wheelchair bound, and his father ended up dying of a heart attack. But he always remembers his dad being in a wheelchair in the 60s and nobody really being able to figure that out. So again, we did a neurologic exam. It essentially showed that he had involvement of weakness in his feet, he had weakness in his legs, he had some mild weakness in his hands. Unlike the patient in case 2, however, he had a fair bit of pain, which was interesting to us. And so we again did this, what we do as a matter of routine, where we send for lab tests. We also referred him for an EMG. And the EMG this time also showed and proved that he did have, in fact, a neuropathy. Unfortunately for him, he did not have evidence of demyelination, which is something that, as neurologists, when we see that, we almost get excited because it's something that we can treat with one of these immune therapies and patients do quite well. He did not have any evidence of that. And his lab tests were fairly unremarkable. 20 years ago, or maybe 30 years ago, we may have sort of put this patient in the category of hereditary neuropathy with an unclear cause. Maybe we would call it an idiopathic neuropathy. We wouldn't be sure. We would just follow him and try to help him the best we could. Nowadays, however, we have far easier access to genetic testing. And in his particular case, we sent out this panel, which has up to 72 genes now, and there's more and more genes every year. And we got a hit, and the hit was on in the TTR gene. So this patient had a condition known as hereditary transthyretin amyloidosis. What you need to know essentially is that it's a protein that's made by the liver that folds abnormally and accumulates in different tissues in the body. And that history that he had, where he had a history of glaucoma, and also a history of a pacemaker at a fairly early age, were actually a canary in the coal mine, that there was maybe something else going on. And what we found out was he actually had a neuropathy from this abnormal protein that was accumulating in and around his nerves. I would say as early as 3 or 4 years ago, when the patient had this, there were a few medicines that we could put patients on to try and stabilize this protein from misfolding, but they didn't work tremendously well. They had some effects, but it was mild. But last year, there were 2 new genetic therapies that came out for this. So therapies that actually treat the genetic cause itself. So this is very exciting. These papers in the New England Journal came out in the same month. One was for patisiran and the other was for ionotersen. And the medication actually works to, it affects the transcript which in the cell, which produces this protein and gets it to stop producing this abnormal protein. And this is not the only genetic therapy we have. On the screen, you'll see we now have genetic therapies for a pediatric condition called spinal muscular atrophy. They're also working on genetic therapies for another pediatric muscle condition called Duchenne's muscular dystrophy. And this hereditary transthyretin amyloidosis is just part of this opening salvo of genetic therapies that we now have at our disposal. And the therapies do exactly what they're supposed to. So in this particular case, this abnormal protein, in the black, you see this is what a patient not on the drugs level looked like and was sort of coasting at the same high level. And then they start the therapy, and in weeks, that abnormal protein, which is building up in their blood, just hits rock bottom. And patients actually report that they are improving, not just stabilizing, or improving with the medications. So this is really, really exciting stuff. As a newly minted neurologist, I'm very excited to be part of sort of the opening of these genetic therapies, and we're only discovering more and more every year. So in summary, with these cases, I hoped that I made a fair argument that we as neurologists like to individualize our assessment based on what a patient comes in with, both their symptoms and their past medical history. And then the treatment is also based on what the underlying cause is and what a patient's chief symptoms are. And our focus is typically, we try to be as focused as possible, not only on the primary condition, how to treat the underlying condition itself, but also on the secondary therapies, which include the symptoms. And we're always working to do better at that.